Hi, I'm David Thompson. I've worked with the Quality and Safety Research Group since it began, really. I've had a background in clinical and health services research in quality and safety for a little over 10 years. I have a master's degree in health policy, and my doctoral degree is in clinical outcomes research and statistical analysis. I've been working with Peter on improving patients' care in the ICU for almost 10 years now. And I'm going to begin by talking about shadowing another provider. It is one of the CUSP tools that we highly recommend for teams. So shadowing another provider has to do with gaining a perspective of other providers that you work with. We developed this tool after we realized that a lot of our providers had no idea the limitations and practice responsibilities of their other members of their team. So physicians wouldn't know the limitations of a medical student or a house officer, or when a house officer needed to seek supervision from a leading physician. We sat down, we put this together to help identify some of the practice responsibilities and to learn a little bit about the work environment, the teamwork and communication hazards that are there, and to identify how we can improve teamwork and communication that may impact patient care delivery, and clinical outcomes. So who should have this experience? Actually, this experience should be open to many patient care areas that are part of the Comprehensive Unit-Based Safety Program. So many of the Hopkins units have already participated and have used the shadowing technique. We have recommended it for staff that have taken a culture assessment like the Safety Attitudes Questionnaire or the AHRQ tool that have scores of less than 60% in teamwork and communication safety. We also recommend when there is a big difference, at least 20% between culture scores between the provider types. So that would be if the nurses had scores of 40, where the physicians ranked nurses having scores of 80. There's a big dichotomy there. Those would be good people to shadow each other, the physician shadowing the nurse and the nurse shadowing the physician. We've also found that this is a very important and integral part of orientation to a new unit. It gives the staff member opportunity to follow respiratory therapists, residents in training, medical students, and to spend a day at the pharmacy. And also for units that have little collaboration between the disciplines, i.e. physicians that rarely get to work directly with the nurses, or nurses that rarely get to work directly with attending physicians, where maybe the intermediary is a resident physician and or nurse practitioner or physician assistant. So how do we do this? We recommend that the night before or the hour before you have your shadowing experience, that you review the tool prior. You follow your healthcare provider through their daily activities. Now, we recommend that you spend somewhere between 2 to 4 hours. We recommend really 4 hours, but we recognize people are very busy. On new orientation, I know that some nurse managers have had nurses spend 4 hours following a resident, 4 hours following the respiratory therapist, and 4 hours following the pharmacist. So it was a whole day, but 4 hours with each one of the different disciplines. So at the end of it, you're going to review your list of communication and teamwork problems that you identify. And these are things that you see as definitely being an obstacle to providing good patient care, that identify teamwork and communication issues that you notice amongst team members. You're going to discuss with the provider that you follow, and then you're going to sit down and make a plan to resolve the issues that you've identified. And you're going to discuss that with whoever has given you the opportunity to participate in the shadowing experience. So we developed the tool to be easy to use. We set it up with questions and prompts for personnel using it. And the reason we did this is because a lot of people in a new environment aren't really familiar with some of the things that they should be looking for. We set this up in order to be very broad so that any provider, whether it be a doctor, a nurse, a pharmacist, could pick this up and begin using it. What we've done is we've made it a very editable tool so that you can make the questions unique to your unit. So if there's something specific that you're already aware of and you want to assess the staff's assessment of whether or not they're identifying the same teamwork, communication, and patient flow areas, please, by all means, go ahead and update the tool to meet the needs of your unit. We want it to be specific to your site. We want it to provide you with the most opportunities for change. Section 1 begins with, were any healthcare providers difficult to approach? So this was one of the first things identified in an interdisciplinary group of providers. And the reason it was identified was at the time we had no communication or no method of identifying problems with each other in weekly staff meetings or interdisciplinary program. So we set this up to learn about what the impact of having somebody difficult to work with was going to have on your opinion of working with them, but also on the outcome for the patient. So how did the difficult provider impact the healthcare that was provided? Were you able to obtain the orders that you needed? Were you ignored? Did you develop a workaround? Did you seek somebody else to get your orders from? Was there a final outcome for the patient? And what was that outcome? Was there delay in care, or did you delay getting the medication into the patient on time? Did you fail to report information such as laboratory values or a radiograph because you were uncomfortable approaching the provider? This has been one of the most difficult things to address, and I'm happy to say that as we've delved into this deeper by shadowing different providers, this is becoming less of a problem here at Johns Hopkins. So did any one provider get approached more often for patient issues? This was written because what we noticed was when there was a provider that was difficult to approach, they went to the provider that was much easier to identify, ask questions of, and get them to come in and assess your patients. So we found that on units where we had maybe 2 residents or 2 nurse practitioners, that if there was an opportunity where one was approached more, we wanted to see how did that impact the care delivery. So we wanted you to think about things like, was it because another healthcare provider was difficult to work with, or was one provider just easier to gain attention from and to seek the healthcare that you needed for your patient? In the long run, this taught us to kind of develop a mechanism to treat both providers the same and give them feedback about how one could improve and how one could lessen their responsibilities on the unit instead of picking up the slack for the provider that was difficult to approach. So sections 3 to 5, did you observe an error in transcription of orders by the provider you followed? Now, this can be done in several ways. You can see this occur with the unit clerk taking off orders that are written physicians. In ICU rounds, we often have the attending physician or fellow doing the talking or describing the error, describing the orders that they would like delivered for that patient care. Then you have another physician, usually a resident in training or a nurse practitioner or a PA, actually transcribing the order as the other one speak. At the end of rounds, we often notice that some of the things that were mentioned were not completed. A lot of times when we're looking at electrolytes and infusing Lasix strips, we'll see that it says, please give 20 milligrams of potassium and please give 40 milliequivalents of Lasix. So we've transcribed, he's heard both of the medication orders, but he's gotten how they're delivered and how they would be written confused. Did you observe an error in the interpretation or delivery of an order? Now, this is very pertinent, especially if in your unit you're using a verbal order system or that you don't require the physician to hand enter all of their own orders. And this is important because not only does it show that maybe you need to implement some readback, but it also means that maybe you're not using active listening, that you're not listening till the order is finished being delivered before you're walking off to complete the order. Were patient problems identified quickly? Always important when you're assessing a patient, how quickly was the physician able to identify problems with the patient based on the nurse's assessment, and vice versa. If the physician says, I need the nurse in this room now, and explains the event, they need to be able to identify what needs to be done quickly. So if it's medication that needs to be administered, if it's line placement, or if they need to get the patient prepared to go off the ICU for a road trip, say for a CAT scan or MRI. All very important reasons to make sure that problems are identified quickly. So if you are following a nurse, and we put this in specifically for pharmacists and physicians, did you observe that in a crisis or when there was an important issue, a nurse's page or phone call was not returned quickly? The reason this question became so important was we noticed in observation in most ICUs on any given day, of the 12 to 14 nurses that we would be working with, that many of them would call a house officer as many as 5 times without a return page, even when it had to do with the patient being in a very serious condition. And that usually we had to go above and beyond the hierarchy that was set, so we had to go over the resident's head to call the fellow and or the attending to seek appropriate care. Then if that does occur, what was the outcome for the patient? And often we find that there's been a delay in patient care delivery or delay in assessment by the provider that is most autonomous in making their decisions. You might want to change this. If you're following a nurse, there could be many other things that you want them to look for. How the routine is set up. Do they have nurse assistants or nurse extenders to work with them? Are nurses primarily responsible for the patient in the ICU, working with a group of nursing assistants or nurse extenders, or do you have an all-RN staff, which may change care delivery? And then we have if you were following a physician. So this is for the respiratory therapists, nurses, and pharmacists that are working with physicians. If you're following a physician, what were the obstacles that a physician faced in returning calls or pages? And we find that often they are their routine activities. They're already seeing a patient. They may be in the OR. They're assessing a new patient in the emergency room. So when you identify things like this, these are the things that we want you to begin to look at to see how we can address getting the patient seen without the physician being pressed for time. So what other factors impacted their ability to see patients? And that can be call schedules, that can be M&M rounds, that can be their weekly conference or library club reviewing an article. And if you identify things like that, what can you do working with the physician to make them more available to provide patient care? We lastly would like you to begin to assess some of the traditional things where we know that there are problems with teamwork and communication, such as handoffs. So you want to watch a nurse hand off to another nurse, a physician hand off to a physician. You want to, if you observed a crisis that day, how was the communication during a crisis? You want to note things like, if a physician says, I'm the only one that should be talking, is that advantageous or is that actually a problem? Does that mean that a nurse with important information couldn't speak up to tell the physician that she sees blood coming out of the chest tube really quickly? Provider skill. So how would you assess their skill? And this is not just their technical skill, but their communication skills and bedside manner. So what could they do from your opinion, to improve the care that they're delivering? And then staffing. Did you feel like there was adequate staffing? And this is at all levels. Did you have enough physicians? Was there alternative care providers, PAs or nurse practitioners that could have filled in? Was there adequate nursing staffing? Did it look like the nurse-to-patient ratio was safe and that optimal care was being delivered? Then lastly, there's a chart under Section 3. What will you do differently in your clinical practice? And 4, what would you recommend to improve teamwork and communication? So there's a specific section under specific recommendations and then your actions taken. So some of the many things that we've seen for recommendations are when a physician is off the floor, that he leaves the pager of an alternative provider so that patients don't have to wait. We also have on-call schedules posted, have been some of the things. We also have the hierarchy of the hospital for physician care delivery, including mid-level practitioners such as PAs and NPs listed daily so that nurses have easy access to those physicians. We've also had an emergency page number. If you can't get hold of the primary provider, please call this number. And the active intensivist or the unit intensivist will be available. And then how you begin to address those actions. And many times these are quick fixes, and sometimes these take a couple of months of working with all the providers on your team to develop a plan that is going to provide for the best patient care and the best work environment, because we want improved teamwork, we want improved communication, because overall it will make where we work a better place to live, and it will make where we deliver care safer for our patients. Our findings to date, that right now with the nursing shortage, we've had over 400 medical students shadow our nurses in the critical care areas. And one of the first things they noticed, since we identified handoffs as problematic, was that when you have a nurse covering for 4 hours, it increases the opportunity to forget key details, as this increased the total number of people that were reporting off to each other. So instead of 2 handoffs a day, we were looking at 3 handoffs daily and then another handoff in the evening. Physician consults usually obtained but not always read by the requesting team. And this is because with the way care is set up and delivered, we have the consulting team that comes by, they make their assessment, they fill out their consult, they place it in the patient's record. But that does not mean that the team requesting the consult has actually been back to read the information and their recommendations for providing care. One of the things often identified is that the bedside nurse, and it's very much been my opinion that they're often the most informed, but they do not always speak up. That nurse has been with the patient for 12 hours. But unless you ask them a question, they're not always going to be transparent about what they've been told. And that's led us to realize that we need to do some assertiveness training in our teamwork and communication classes for the nurses. Nurses, the provider, most often last with the patient information. So in those examples where a consult was obtained, that information is often less with the nurse. There's few conversations directly from primary physician to primary physician. So the nurse, it's in their hands to pass on the information to the provider. It is not always effective. The nurse is not always at the bedside, especially when one nurse has 2 patients. So there's always this opportunity for missed information, even if it's important, about getting a patient maybe to a test or for other studies, that you need more direct communication between the primary teams. For us, we realized pharmacists did not realize how critical it was supplying our Pyxis machines and stock drugs. And stock drugs in our ICUs are kept in the refrigerator in a non-locked cabinet, as well as the Pyxis machine. And stocking them once a shift was not adequate, because if you have an ICU with 18 patients, you can easily go through the stock drug. And for us, I think it was Esmolol. And we have Esmolol in its full strength, and then we have Esmolol that's mixed up so that it can be delivered IV if the patient develops a high heart rate. And it significantly increases the time that the patient is going with a elevated heart rate, because it takes time to mix the medication. So we've had some changes from pharmacy. As I said, some providers were avoided. These are the ones that have been difficult to approach, those that have been verbally abusive and or sarcastic. The electronic medical record was not accessed, and usually that was by the interdisciplinary team, because we have not developed a uniformly electronic medical record, so that we still need to go to the physician's chart for the history and physical and some of the daily progress notes, where some ICU providers and nurses can write their progress notes on point of care computer, but it doesn't mean all information by all providers are being evaluated. So that led us to, these steps need to be followed. You need to look at the electronic medical record and then assess for any progress notes that were written in that day. And we have made it so that physicians and nurses can read each other's notes easily without having to access different parts of the electronic medical record. When we had shadowing between our OR staff one of the things that they identified was that they had a difficult time putting together the trays that were needed for the surgical procedures. So we had nurses follow sterile processing, and in an effort to be quick and to be thorough, the nurse had taken parts of the tray down and sent them separately. After following sterile processing, they were able to identify that keeping the sterile trays together for procedures done at the bedside or at the OR allowed for a quick return from sterile processing. We also had sterile processing come up and assess how the nurses handled the equipment after it had been used, and that also improved the amount of time, decreased the amount of time that it took to get sterile processing to deliver needed trays. After implementing physician order entry, we realized that an important step of communication between the physician and the nurse for stat orders was missing. It used to be policy that if a stat order was written by a physician, he had to notify in person the nurse to let them aware of that. With physician order entry, the order could be implemented, the stat flag could be identified, but we lost that important step of the actual communication. Nurses are only required to look at the physician order entry in the ICU every hour. On the floor, it's every 4 hours. So stat orders were not being given in a stat fashion. So we had to put back in that nice little important step of direct communication between the physician and nurse for stat orders. We also learned that unlike how nurses are trained when they're hired, they come in and they read all the policies and procedures for the unit. Physicians do not have that luxury. They're not giving a day to identify all the unit policies that may affect their practice. So physicians are very dependent on the RNs to complete the task. So it behooves the nurse to inform the physician rather than let the mistake go unnoticed, or to bring it up later that says the physician didn't get a chest x-ray after placing the chest tube. It's the nurse's responsibility to let them deliver their care, and then to let them know what else needs to be completed in them in order for them to complete their task. Some nursing practice should be used hospital-wide, such as labeling. In the ICU, all of the medications have a label where the medication starts, and at the hub where it infuses into the patient. Physicians that have been in the ICU that have been called to codes on the floor had recommended this practice for patients on the floor because they were able to easily trace what lines were being used, so they could have a safe line to deliver medication, and they could also have the ability to easily identify medications that the patient was currently receiving. And I'm sure this doesn't surprise anybody, but isolation policies are not adhered to, primarily physician personnel, and it's mostly consults. And we've had a very active program, again, in which we've had to support the nurse in speaking up to the physicians. So when they see this practice, they can ask the physician to go back and put on the appropriate hand gloves, masks, and gown in order to see the patients that are on isolation. And as I said, assertiveness training was indicated. But not only was it indicated, we also had to have middle management be supportive of what the nurses were doing, so that if a nurse had to stop a physician, whether it be stopping them to enter a room and put on the appropriate gown, mask, and gloves, or whether it was stopping them because they weren't following procedure for placing a central line, that the nurse needed to know that middle management was going to support them. And that was more important than making sure that you had a checklist, because without having the support of middle management, nurses were too often quiet when they saw things that physicians were doing and they didn't speak up. And it only negatively impacts our infection rates. In closing, as I said, the shadowing tool has been used by well over 400 members of the medical school students that we've been training. It has been used by hundreds of nurses and physicians from critical care to traditional inpatient floors. As I said, we've also used it for the emergency room to track progress of the disconnect between handoffs from the emergency care provider to our medical ICU. It has been a benefit. It's one of the probably favorite CUSP tools that we have. And annually, our findings that we write up are presented to the Johns Hopkins Safety Board for their review to see other ways that we can improve physician communication to nurses, nurse communication to physician, and care delivery to better improve our patient outcomes. Good luck.